Welcome back. Let's talk about coronary artery disease, CAD, in here. So, the normal physiology of coronary circulation should have been reviewed at this point for you to be able to understand coronary artery disease. The details in summary is what I would like to bring up again here before we talk about coronary artery disease itself. That is, coronary arteries supply the heart, and the cardiac muscle is the main user of oxygen because of its increased activity. And in fact, most of the oxygen that's available in coronary supply is used by the muscles. If there is any increase in size of the muscle fiber, there is no increase in blood supply. That means poor availability of blood and therefore oxygen and therefore ischemia. And ischemia for some time is reversible. Okay, so what happens is if blood supply is limited, the cardiac muscle fibers can switch to anaerobic respiration temporarily. This is about 20 minutes approximately. And then if conditions have not changed for better, then this becomes irreversible. So ischemia leads to necrosis of muscle fibers, cell death, and that's what you call as infarction. All right, so that's what you're talking about. Here we are associating coronary blood supply to the muscle function, where coronary artery is not supplying sufficient amount of blood. There is a disease within the vessel. Okay? Somehow there is occlusion or damage to the vessel. So all of this could cause coronary artery disease. Okay, so normal blood supply itself is a challenge for the heart to keep up, but now with the disease, it is going to be inevitable. Okay, so the common cause of coronary artery disease is atherosclerosis. That is the building of plaque within the blood vessel wall. Okay, so if the coronary artery has a plaque built up, what happens is it occludes the vessel. Occlusion can vary from one time to another, and it continues to grow, and the growth impedes blood flow, and that is how the tissue suffers from ischemia and then ultimately myocardial infarction. Okay, so coronary artery disease, ischemia, ischemia to MI. All right, so let's talk about who develops this disease. Well, the blue color here represents male, and here is the age group. As you can tell, its incidence is higher in the older population. Okay, and men suffer from it more than women, and those are two obvious things from this graph. Now the risk factors. Okay, risk factors, as we figured out, it's male, gender, and increasing age. In addition to that, you're talking about hypercholesterolemia. That could be due to genetic abnormalities, due to acquired conditions such as poor diet. Hypertension is another cause of coronary artery disease because the high blood pressure within the blood vessel wall can injure the wall. Injury, inflammation, and coronary artery disease is how you have to connect hypertension coronary artery disease. Cigarette smoking is another harmful factor in many places, including coronary artery disease. The toxic agents harm the cells in many ways, mitochondrial injury and so on. So that is how it's connected. Diabetes mellitus is where increased amount of glucose in circulation, binding to proteins within the blood, within the vessel wall, and then triggering inflammation. Obesity is connected to hypercholesterolemia. Obesity could be linked to sedentary lifestyle. Obesity could be linked to poor diet and genetic factors. Family history are some other factors. Newly identified risk factors include inflammatory agents, thrombotic agents, and the one key agent here, this is an inflammatory marker, is C-reactive protein or CRP. A troponin I, hyperhomocysteinemia, high levels of homocysteine is supposed to be involved in atherosclerosis. Okay, adipokines are factors that are made by adipocytes. Please note, adiponectin is supposed to be protective against atherosclerosis, but decreased levels of adiponectin could be a risk factor. Leptin is the hormone that limits the amount of food you eat, and decreased amount of leptin could lead to atherosclerosis simply because of overeating, and then the hypercholesterolemia, obesity, all of that. Infection is where microorganisms, periodontal disease, they cause inflammation. Inflammation could be the cause of coronary artery disease, and then coronary artery calcification is another factor, that is hardening of the vessel wall, replacement of normal cells by fibrous tissue. Okay. So now we'll talk about myocardial ischemia in detail. Okay. So ischemia within 10 seconds of coronary occlusion, 10 seconds of occlusion, a limited blood supply, it would switch to anaerobic respiration. Okay, so one complication of that is the buildup of lactic acid. Right, lactic acid can cause local acidosis and acidosis of the blood. All of that. Myocytes are viable for about 20 minutes in anaerobic respiration pattern, and during this time it's a reversible condition. If the situation got better, then everything is back to normal. If not, then it would switch to MI. We already talked about common causes of atherosclerosis, growing mass of plaque associated with platelets, fibrin, other debris, narrows the coronary artery, lumen to impede blood flow. Cannot meet the demand of the myocardium for oxygen and nutrients, leading to myocardial ischemia. Other causes, increased resistance in the coronary arteries. Okay, so high blood pressure, increased resistance, there is less flow of blood. Okay, hypotension. Hypotension is where, how do we think about hypotension, is there is less pressure to move blood from the coronary artery into the ventricular wall, where the pressure is probably higher than the pressure within the artery. Okay, remember, there is a fine balance. You have to have higher pressure in the coronary artery compared to the pressure within the ventricular wall. All right, arrhythmia, valvular incompetence, shock, all these basically affect blood flow, amount of blood being ejected by the heart, or anemia again is less oxygen available. Okay, increased demand for blood supply due to high blood pressure, increased ventricular volume, left ventricular hypertrophy, increased heart rate, and valvular disease could be another cause too. Okay, so some conditions here would demand more blood supply, and because of the increased workload, and that may not be met because of the limitation with coronary blood supply, and that would lead to ischemia. Now let's talk about angina pectoris. What is this? It's the pain associated with ischemia. Okay, so here you're talking about cardiac ischemia, myocardial ischemia. Then the chemicals released locally, just a few are mentioned here, adenosine, bradykinin as examples. They bring specific type of pain, and that is what you refer to as chest pain. Okay, so angina pectoris is nothing but chest pain associated with myocardial ischemia. Okay, pain is in this crescendo, decrescendo type, so that is the high sound, then gradually diminishing, and then high-low. It's not sound here because it is pain, but then high to the diminished pain type of pain that radiates through many parts close to the heart. That includes the neck, the left shoulder, left arm, and jaw, and often people may perceive this as epigastric discomfort, shortness of breath. All right, so partial occlusion or a chronic narrowing of a segment of coronary artery is going to lead to stable angina. Stable angina is where one can predict when the pain comes and goes. Like climbing the stairs is when probably a person feels the chest pain. That is stable angina. Okay. Extreme imbalance leads to congestive heart failure, electrical instability with cardiac arrhythmias, and MI. Then chronic stable angina, we already looked at that, just pain that does not change over 2 months or longer. Unstable angina is sudden pain, angina at rest, angina of new onset, or an increase in the severity or frequency of previously stable angina. Without an increase in levels of cardiac biomarkers such as troponin I and CK-MB levels. Okay, ST segment depression would coincide with angina, so electrical activity can be seen in ECG that has some specific changes. Okay, let's talk about unstable angina a little bit more. It's reversible myocardial ischemia. Okay, myocardial ischemia that can still be reversed. So it's transient episodes of thrombotic vessel leading to occlusion and vasoconstriction occur at the site of plaque and return to perfusion before significant myocardial necrosis occurs. So this is a reversible pattern, and there is transient episode, okay, of coronary vessel, thrombotic vessel. Here for us is coronary vessel, okay, to occlusion and vasoconstriction occur at the site of plaque temporarily, okay, then return of perfusion before any major damage happens. So this is reversible. Okay, so unstable angina is where you can never predict when it comes, when it goes, and that could be because of its reversible nature. Okay, so 5 causes: rupture or erosion of the coronary plaque, and non-occlusive thrombosis is how you refer to that. and then dynamic obstruction due to vasoconstriction. So there is plaque, but vasoconstriction would worsen the condition. And then worsening coronary luminal narrowing due to progressive atherosclerosis. Okay? The growth of this plaque has expanded, or restenosis of in-stent. So stent being replaced, or narrowing of cabbage. This is the procedure that would be done as a bypass surgery, and that is where the vessel is narrowing, where the replacement was made before. Inflammation and MI are the two other key causes. Okay, so unstable angina is what? Unpredictable pain associated with ischemia. Okay, now we talk about acute coronary syndrome. Acute coronary syndrome is when there is sudden impact of coronary supply. Okay, sudden coronary obstruction is what you call as acute coronary syndrome. So the consequences are still the same: obstruction of the coronary vessel suddenly, right? Maybe because of thrombosis over a ruptured atherosclerotic plaque, or maybe because of vasculitis, that is inflammation locally, or there is dissection of the aortic root of coronary artery itself. So those are major impacts. All right, sudden coronary obstruction from whatever reasons mentioned here, all right, would lead to MI, okay, unstable angina, MI. Most common complications are dysrhythmias, congestive heart failure, sudden death is the ultimate thing. Okay, here it is, coronary artery syndrome. That is when coronary arteries occluded suddenly. Okay, so ischemic type of chest pain, stable angina to new onset. This is before. All right, new onset or change from baseline acute coronary syndrome. So this is possible. There is already an underlying issue, but it gets worse. Okay, acute coronary syndrome. Or maybe a new one, dissection of the coronary artery, whatever it is that leads to coronary, acute coronary syndrome. Now we are looking at changes. Here you are looking at ST segment elevation, right, as well as the biomarkers troponin, CKMB levels are high, and the ECG shows STEMI. Okay, ST segment elevation is STEMI, and that leads to MI. Okay, so now acute coronary syndrome could also have no ST segment elevation, but you still have troponin, CKMB levels being high, and non-STEMI, myocardial infarction is still possible. Okay, here is another alternate one where you don't have the biomarkers troponin and CKMB, but it is just the temporary condition. That means they did not have loss of muscle fibers. It was a reversible condition. Okay, acute coronary syndrome that could be reversed. So you have unstable angina. Here it is a permanent situation where you have myocardial infarction. So two possibilities with acute coronary syndrome. One is unstable angina, one is MI. Got it? Good. So two major types of myocardial infarction. Okay, we just saw that there. And one is subendocardial infarction, the other one is transmural infarction. Transmural infarction is the most serious kind. That is where the infarction is within the wall, okay, within the actual myocardium. Okay, so that is transmural infarction. Individuals at highest risk for complications, ST segment elevation is seen here, requires immediate intervention. Subendocardial infarction is where small infarctions, they're not associated with ST segment elevation. Non-STEMI is how you refer to that, depression of ST segment. It's not the elevation, but depression and inversion of T wave without Q waves. Okay, so those are the differences. And you will see the ECG pattern. This is normal ST segment depression with the non-STEMI, you see. And then T wave inversion is this one here. That's also non-STEMI. ST segment elevation is STEMI. Okay. Criteria for diagnosis of acute myocardial infarction. Okay. So you're looking at detection of rise and fall of cardiac biomarkers, troponin levels mainly, and then symptoms of ischemia, ECG changes, and development of pathologic Q waves on the ECG, again, ECG changes, and imaging evidence to prove the same. Here is an illustration of what to expect. Here you have the cardiac muscle fiber. There is some free troponin and some bound to tropomyosin. And this is the complex, troponin complex and troponin free. Here, troponin free would be immediately released, and that is what you see in the first less than 1 hour. Okay, then with the size of the MI, you may see a bigger troponin shift here in blood levels, or a smaller one with a smaller MI. Okay, so troponin levels indicate how big of an MI this patient had. All right, so acute myocardial infarction clinical manifestations when the person has an MI, typically there is a zone of injury. Okay, those are the parts with the dead cells, necrosis. Okay, and they may return to normal depending upon the duration. And adjacent to that would be where you would see reversible ischemia. So usually one area, like the center of it, would be made of dead infarcts, versus the area surrounding that would be where there is ischemia, but it is reversible depending upon the condition. And chest pain or angina, ECG changes, and troponin I levels increasing. Suddenly, that is the free troponin, and then the higher levels of troponin I measurable within a few days, 1 to 3 days, that is, creatine phosphokinase MB, CKMB levels also increase because they are in the myocardial cells. All right, non-STEMI myocardial infarction is where you have angina at rest, lasting greater than 20 minutes, okay, unless there was interruption of that through medication. Nitroglycerin could be one, chronic angina pectoris that becomes more frequent and more easily provoked. And then new onset angina, that's severe, prolonged, disabling ST segment elevation. So these are the expectations to consider non-STEMI myocardial infarction. So although it is non-STEMI, it could change to STEMI, right, in order to develop MI. Complications of acute myocardial infarction or MI, it could be post-infarction ischemia, okay, cardiac dysrhythmia, pericarditis. These are all heart conditions, as you can tell. Mitral regurgitation, and then the interventricular septum ruptures, or myocardial dysfunction, cardiogenic shock, where there is very little blood being ejected, myocardial rupture. So you saw the septal rupture, here you're talking about rupture elsewhere, right ventricular infarction, and then mural thrombus or stroke causing MI. All right, that's the end of this lecture. We learned a lot about coronary artery disease and how that can affect the heart function or basically lead to death ultimately. All right, thank you.